We are starting our Presidential Plenary 2. I hope the speakers are all here. The first talk, which is also presented at the Residents and Fellows Conference, will be presented by Dr. Famularo, and it is preoperative detection of hepatocellular carcinomas, microvascular invasion on CT scan by artificial intelligence and radiomics analyses. Please sit down and pay attention. Thank you.
How can I move with the...
I think if you hit, it's showing. And then you press the left button.
Perfect. Thank you very much. So, thank you very much. It's a great honor to be here today. So, probably all of you knows how microvascular invasion is a very important prognostic factor in the field of hepatocellular carcinoma because it impacts both survival and recurrence. It has been estimated to be present up to 45% of the cases, and it has also been inputted recently in the progression history of this tumor because its presence has been correlated with the presence of a systemic disease, like in case of circulating tumor cells. However, we know that microvascular invasion is present only after surgery, so once we have provided the histological specimen. Nowadays, there are no way to have this information before starting the therapeutical plan. Why it can be important? Recently, we published a meta-analysis where we showed that in the context of patients with microvascular invasion, just to make an example, the best standard practice, the anatomical resection, seems to reach exactly the same results of a non-anatomical or parenchyma sparing surgery. So we can use this information, for example, to determine the surgical technique preoperatively, but also in the near future to establish, for example, who may benefit the more for neoadjuvant or adjuvant chemotherapies. So the aim of our work was to develop a machine learning algorithm able to predict microvascular invasion at the preoperative CT scan by the extraction of radiomics features, and secondarily to develop a software able to automatically extract the radiomics features and to make such predictions. We collect CT scans from 15 centers in Italy. Today I'm presenting you the preliminary results where we analyze the CT scans from 5 centers, and the clinical data were retrieved by the Hercules register. So we started our adventure with our radiologists that manually use LifeX, that is an open source software you can find online, to manually annotate the one single slice in 2D of a CT scan, detecting the tumor, the peritumoral area, and the whole tissue part of the liver. From these 3 points, we extracted the radiomics features in each single phase of the CT scan. By this, we tried to train 3 models to understand which one was the best: random forest, extreme gradient boosting, and a fully connected neural network. And for hyperparameters tuning, we use a tenfold cross-validation and a grid search strategy. We split the dataset among 70% of the data to train our model in detecting the presence of the presence of microvascular invasion, and then we evaluate the results of our model in a test set that was the 30% of the data, never seen obviously by the machine before. So, to make us more recap, we start from the CT scans, we manually annotated the liver and the tumor, we extract the radiomics features, we train the 3 models in order to predict the presence of microvascular invasion. So, between 2008 and 2022, we collected almost 548 CT scans, but in this analysis, we just analyzed almost the 40% of this data. You can see here the baseline of our cohort, and most importantly, please note that the microvascular invasion was detected up to 33% of the cases. From each single patient, we extracted 671 features. So, as you can imagine, this creates a very large noise for making good predictions. So, we needed to find a way to reduce this type of noise in order to create a proper and a good algorithm. No? So, we decided to use a PCA, a principal component analysis, by which we reduced from 671 variables to 58 dimensions, keeping the 95% of the variance of the starting data. Those are our results. I put also the hyperparameters for those who can be interested, but please focus your attention on the confusion matrix and on this table. As you can see, we were focused on the accuracy. In the trained set, we reached very good understanding results, but once we tried the models in data never seen by the machine, the results were terrible, dropping down very importantly. The same observation was made for neural networks, which it was exactly the same. In the training set, the model created a very important overfitting, but in the test set, finally the results were not satisfactory. But once we tried the random forest, surprisingly, we reached a very good results because as you see the accuracy, we arrived to 98.4% of accuracy in the test set with very good positive predictive value and negative predictive value. So once we go to the secondary aim, so to test and to challenge what the radiologists can do and what the machines can do now, what we discovered was that the machine was able to make the same annotation of the radiologist in the 83% of the cases regarding the liver, but only on the 44% of the cases once we were speaking about detecting and annotate the tumors inside the liver. So those are obviously Italian data, so we definitely need to make an external validation to be sure that those models can work effectively even in other settings. We still need a radiologist to extract the features, so we need to implement the automatization part of our project. And more importantly, we don't know actually if those radiologic features have a biologic role impacting the disease or if they are only numbers. But this is the mystery of the machine learning black box that is one of the pivotal points that are discussing nowadays in the public debate. In the near future, we want to enlarge the data. We will test new models to discover if some other models can be better in the prediction. We're going to improve the features engineering, the data augmentation to solve the imbalance problem. And then we will increase the training for the automatic segmentation. And finally, we will develop the software that will be freely available online for everybody. But please let me spend a few seconds, a couple of words about something that today is very important because everybody knows about ChatGPT and the public debate that is starting to open all around the world. So the main questions, particularly in medicine, is AI will be the inevitable futures of human doctors. But probably now everybody thinks yes, but if we follow the white rabbit beyond the mirror and we go to see better what are we targeting, we know that, for example, machines are not Deus ex machina, so we cannot expect those outstanding results. What is working on our data when we look into the actual publication in PubMed seems very good, but we don't know if that models will work on other data, and this is very important. And then how the knowledge provided by the AI should be employed ethically and technically should be better debated. And before translating AI in the clinical practice, we definitely need to better discuss the implication for patients, for doctors, and for all us community. Because finally, investigating machine learnings, it's like this guy on the rope. We need to go forward, but we need also to be very cautious since the implication can be very, very dangerous. So, just for concluding, the results we are obtaining, looking to the literature, seems very incredible, but please be aware because it's very easy nowadays to publish once you add the word machine learning in the title of your paper. But we definitely need expert reviewers in our journals about this type of models to be sure of the quality of the data we are introducing in the literature, to be sure about what we are discussing. And finally, we definitely need a surgical consensus on how to investigate this field, how to report, very important, and how to validate those models. And for example, this can be the role of a society such as the SSAT, creating like such a commission, for example, to open the debate and, for example, to elaborate a statement about this new type of science we are gonna doing all around the world. But don't worry, what's the target? We need to better understand these machines because the goal here is not to create something that can substitute the humans, but we are working to better create something that can be a support in our decision-making pathway. But don't worry, and I'm really concluding, because machines, I don't think, are almost to substitute humans in the very early futures. This is a Twitter that Professor Shade, I don't know if he's in the room, published a couple of weeks ago. He tried to ask to one of those artificial intelligence available online to recreate the liver anatomy. And this is the results the machine provided. So don't worry, as Professor Shad says, we are not losing our job in the very near futures, okay? Thank you very much for your attention.
Okay, thank you very much for the presentation. Outstanding job. Very impressive results, and I'm very delighted that you took the time to set out the precautions that we need to take in interpreting them. I look forward to you validating this in a larger cohort than the 64 in your test group. I have a few questions for you pertaining to this. Number one is, to what extent does the quality of the imaging impact the ability to draw out these features? Number two is, rather than just look for MVI, for instance, is there a way to use this tool to prognosticate even those features that can tell you about patients who will recur very early or whose survival will be limited to determine whether or not they would benefit from surgery? And thirdly, are you currently applying this in your decision-making with regards to whether to do an anatomic or non-anatomic resection? Thank you very much.
Thank you for your questions. So I start from the last question that I think is the most important. As I was saying, now we do not apply those algorithms in our clinical practice. First, because we are developing the model, so actually it's not ready. But secondly, because we don't know the clinical implication of such applications. We need to investigate that. So for the moment, we are just working in a scientific environment, and those results are not applied on humans, not at the moment, okay? About the quality of the CT scans, yes, this is a very large problem. Actually, it's a problem more with the MRI scans rather than the CT scans that are usually more similar between the centers. We decided to start those analyses just in 5 centers because we were sure about the protocols of CT scans acquisitions, and we knew that they were exactly comparable. But we will see in the once we're gonna further to enlarge the data if it will work properly also in the other set. But also consider that for making these models, we are working on a single 2D slice of the CT scan. So probably the quality of the CT scan, it shouldn't be very important because you just need one picture, no more.
Great. Okay. Thank
Thank
you
you.
very much. Next paper is Bariatric Surgery Decreases the Risk of Developing Cancer, a Multi-Center Population-Based Study, presented by Dr. Chidachola from Digestive Diseases Health Institute, the University Hospitals, Cleveland.
Thank you so much for inviting me to speak today. The prevalence of obesity has only increased in the past years, as you see by the graphic by the CDC of self-reported obesity among U.S. adults by state and territory from 2021. All states and territories noted more than 20% of adults with obesity. Additionally, it is predicted that by 2030, nearly 1 in 2 U.S. adults will have obesity, and the prevalence will be higher than 50% in 29 states and not below 35% in any state. Obesity promotes the incidence of additional medical conditions. Hence, with increasing prevalence in obesity, we are also seeing an increasing prevalence of these obesity-associated comorbidities. As you can see in the figure, obesity is associated with multiple categories of medical conditions ranging from psychological, cardiovascular, metabolic, and malignant. Bariatric surgery is one of the most effective tools for the treatment of obesity. The impact of bariatric surgery and its protective effect for patients with obesity from developing de novo obesity cancer is a field of active study. There have been few retrospective studies that demonstrated a lower incidence of obesity-associated cancer in patients with obesity who underwent bariatric surgery when compared with no surgery. However, due to smaller sample sizes, it was difficult to distinguish which specific obesity-associated cancers were prevented when patients underwent bariatric surgery. Therefore, we conducted a large multi-center population-based study to further elucidate the protective effect of bariatric surgery against the development of de novo obesity-associated cancers as a whole, in addition to its individual subtypes. We performed a retrospective cohort study from 2002 to 2022, utilizing Trinetics, a multi-institutional database from 47 U.S. healthcare organizations containing data from greater than 101 million patients. We identified patients utilizing ICD-10 coding. We identified patients with BMIs greater than 35 or obesity class 2 and 3, as they would be the patients who would qualify for bariatric surgery. The two study groups we had were a bariatric surgery group and a non-surgical control group. Bariatric surgeries included were sleeve gastrectomy, gastric bypass, and gastric band. We excluded patients with histories of multiple bariatric surgeries, malignancy, peptic ulcer disease, or ascites. We performed one-to-one propensity score matching based on demographics, Elix-Hauser comorbidity index, hormone therapy, and cancer screening. Assessment for de novo cancer diagnosis started 1 year after index date, which was defined as time of bariatric surgery for study group or clinic visit of obesity diagnosis for non-surgical control group. This was done to minimize the impact of capturing pre-existing cancers. All patients required at least 12 months of follow-up designated by at least one visit after 1 year from index date, and patients were followed up to 10 years from index date. Primary outcome was incidence proportion of de novo obesity-associated cancer at least 1 year after the index date for each group. The International Agency for Research on Cancer has identified cancers with sufficient evidence to be considered linked with obesity, which are esophageal adenocarcinoma, multiple myeloma, and cancers of kidney, colon, rectum, stomach, liver, gallbladder, pancreas, ovary, endometrium, breast, and thyroid. Of note, the ICD-10 code for malignant neoplasm of the lower third of the esophagus was utilized as a surrogate for esophageal adenocarcinoma. Additionally, we were unable to differentiate postmenopausal breast cancer or age greater than 55, hence all breast cancer was represented within our study. From a database including greater than 101 million patients, we initially identified 60,285 patients in the bariatric surgery group and approximately 1.5 million patients in the non-surgical control group. After propensity score matching, we included 55,789 patients within each study group. In this table, we are showing 10-year outcomes of obesity-associated cancers in addition to the individual subtypes of malignancy. For all obesity-associated cancers, we noted 2,206 patients in the bariatric surgery group and 4,960 patients in the non-surgical group. This equated to a lower incidence proportion of obesity-associated cancer with 4% in the bariatric surgery group and 8.9% in the non-surgical control group with a hazard ratio of 0.482 and a confidence interval of 0.459 to 0.507. We found few patients with esophageal adenocarcinoma in either group and no statistically significant difference between study groups. We noted 501 cases of breast cancer in the bariatric surgery group compared to 751 cases of breast cancer in the non-surgical control group with a hazard ratio of 0.753 and a confidence interval of 0.678 to 0.836. No differences were seen in incidence proportion for renal cancer between study groups. Less cases of colon cancer were seen in the bariatric surgery group with an incidence proportion of 0.4% in the bariatric surgery group compared to the 0.6% in the non-surgical control group with a hazard ratio of 0.638 and a confidence interval of 0.541 to 0.752. Additionally, no differences in incidence proportions were seen in de novo formation of rectal or gastric cancers between study groups. Next, looking at cancer for the liver, we saw 969 cases in the bariatric surgery group and 2,198 cases in the non-surgical control group with a hazard ratio of 0.370 and 95% confidence interval of 0.345 to 0.396. We did not observe a difference in incidence proportions for gallbladder and pancreas cancers between study groups. For ovarian cancer, we noted a 0.2% incidence proportion in the bariatric surgery group and a 0.4% incidence proportion in the non-surgical control group with a hazard ratio of 0.654 and confidence interval of 0.531 to 0.806. Similarly, for endometrial cancer, we also saw a 0.2% incidence proportion in the bariatric surgery group and a 0.4% incidence proportion in the non-surgical control group, but a hazard ratio of 0.448 and a confidence interval of 0.362 to 0.556. No statistically significant differences were noted in incidence proportions for thyroid cancer and multiple myeloma between study groups. Reviewing the strengths of our study, we must emphasize a large sample size evaluated in addition to the utilization of propensity score matching to adjust for baseline characteristics and potential confounders. Additionally, we believe the clinical implications of the study are significant when considering the morbidity and mortality attributed to obesity-associated malignancies. Nevertheless, we recognize some of the limitations of our study. This study is a retrospective study that is utilizing an administrative database dependent on accurate and complete ICD-10 coding. Due to limitations of the Trinetics database, we were unable to assess socioeconomic status or medical insurance status for each patient that may have served as a barrier to access to healthcare. Additionally, we note a potential healthy user bias in patients that choose to undergo bariatric surgery, which we attempt to account for with propensity score matching. Lastly, we were unable to assess for timing of malignancy diagnosis nor extent of weight loss achieved in either group examined within our study. Through our investigation, we noted bariatric surgery decreased the risk of de novo obesity-associated cancer. We saw that bariatric surgery patients had a greater than 50% lower rate of developing cancer than patients without bariatric surgery when followed for 10 years. We specifically noted lower incidence proportions of breast, colon, liver, ovarian, and endometrial cancer in the bariatric surgery group. We believe that our study has important implications in one of the most common causes of preventable and premature death in U.S. adults with obesity, and hope that encourages further studies within this critically important field. I would like to thank my team members and faculty mentors, Dr. Mansour and Dr. Roberto Simmons-Linares. I'd also like to thank my wife and our 2-week-old daughter, Alora, for allowing me to be here today. Thank you so much for your time.
Thank you. This paper will be discussed by Dr. Ulysses Ribeiro.
Hi, Ulysses Ribeiro from the University of São Paulo, Brazil. First, I would like to congratulate the authors for this interesting study and acknowledge the Bible for sending me the presentation in advance. Obesity increases the cancer risk, and you clearly showed your presentation that after bariatric surgery occurs a reduction of the cancer incidence of several tumors. Some questions to you. Is the bariatric surgery technique relevant for this incidence reduction? In other words, have sleeve gastrectomy, gastric bypass, or gastric band had different outcomes? Is there a relationship between the obesity grade and the cancer incidence? I mean, super obese versus, is there a relationship between the follow-up time and the cancer incidence? I would like to thank the SSAT for allowing me to be your primary discussant, and I'm glad to see your daughter pictures. Thank you.
Thank you. Perfect. Thank you, Dr. Ribeiro. For the first question, this study, so we incorporated sleeve gastrectomy, gastric bypass, and gastric band patients in the bariatric surgery group, but we did not compare outcomes between the different types of surgeries. We hope to conduct additional analysis to further elucidate whether the protective effect against de novo obesity-associated cancer varies based off the type of bariatric surgery that the patient undergoes. As far as the relationship between obesity grade class 1, 2, 3 and the cancer incidence, we did not stratify results based off of the specific category of obesity. We included all patients with BMI greater than 35 or patients that generally meet the criteria for bariatric surgery. But we do agree that it's important to understand if there's a dose relationship of weight loss or initial BMI prior to surgery and then end or nadir weight loss to see if there's a better protection if you're having a more significant weight loss. And then looking at the relationship between follow-up time and cancer incidence. So we noted a minimum follow-up of 12 months to ensure that the extent of weight loss expected after bariatric surgery was achieved. Additionally, we did not assess for cancer occurrence prior to 12 months after bariatric surgery to minimize the impact of capturing pre-existing cancers. Due to limitations of the Trinetics database, it is difficult to determine the specific timing of cancer diagnosis, but we agree that this is an important question to answer in the future to better understand the length of this protective effect after bariatric surgery. Thank you.
Ali Tabakoli, Brigham, Boston, great presentation. It was nice to see the big reduction actually in hepatocellular cancer, which is kind of increasing evidence of the role of bariatric surgery in liver health. My question for you is on the colon, though, because you showed a reduction in colorectal cancer. The data of that has been mixed. Some studies have showed no change. Some studies have shown increased risk of colorectal cancer. So any thoughts on why you saw the pattern you did? And also, did you control for screening behavior? So did you look to see how many colonoscopies patients may have had in the two groups?
Yes. So I think one thing is the size of our study may show different trends. In addition, the way we're identifying patients is through ICD coding. We did propensity score match for basic cancer screening tests such as mammography, colonoscopy, and PSA. So we did our best to be able to control for that, but we recognize that this is based off of ICD coding, and this is not including all types of colorectal cancer screening, including stool testing. Thank you. Thank you very much. Perfect. Thank you.
Our last paper in this session is Extending Quality Improvement for Pancreatic Adenoidectomy within the High-Volume Setting, the Experience Factor, presented by Dr. Canas from the University of Pennsylvania, as well as the University Cicli Studio di Verona.
And so thank you, Dr. Sang and the Society for the opportunity to present our work on the value of experience in pancreatic surgery. So we have no disclosures, so let's get started. While the literature is rife with volume outcomes associations, the concept of experience in surgery remains nebulous and multifactorial, yet an undoubtable contribution to optimal outcomes. It all starts with the surgeon, but which of these metrics best aligns with the notion? Volume, years of practice, hours, or perhaps surpassing the learning curve? And the institution, as well, plays a pivotal role. These metrics have been well recognized as determinants of improved perioperative outcomes, especially in pancreatic surgery. Yet, the interplay of this individual contribution remains curious as we strive for optimal results. Is it just that practice makes perfect? Or rather, like this memorable scene where Hannibal barters, I tell you things, you tell me things, quid pro quo Clarice, there is here a back and forth, a trade-off established here. Well, our own President Sang's work on this topic was foundational, the first to establish the learning curve for the Whipple procedure. After 60 cases, surgeons achieved significantly decreased blood loss, operative time, and lack of hospital stay. So mainly measures of increased surgical efficiency, but just surrogates for ultimate patient outcomes. And to build on this, our previous work has established the practice patterns in surgery on a global scale. And interestingly, the median total number of Whipples performed was just 80. And more alarming is the fact that merely half of all surgeons have surpassed the supposed learning curve. And furthermore, just 10% have performed more than 500 Whipples. So to build on this, we propose the concept of a proficiency curve, where not only efficiency, but rather efficacy contributes to expertise. And we conceive this as a synergistic process where best practices align with institutional strengths to augment the foundations of initial training. So with this clearly in mind, we aim to explore the association of a surgeon's experience with post-operative outcomes across the full spectrum of risk for this very complex, high-acuity procedure of pancreatic duodenectomy. And here is how we went about this. So for analysis, we utilized all cases from the Pancreas Fistula Study Group, which is an international collaboration of 18 high-volume, highly specialized institutions. 82 surgeons participated with over 8,000 Whipples for over 20 years. Now, our primary outcome study was clinically relevant pancreatic fistula, as well as, of course, its downstream effects, which are expected to happen here. Now, the analysis was performed across every echelon of experience, codified as surgical volume in quartiles. Risk adjustment was attained by the fistula risk score, which significantly stratifies each of the studied metrics. And here is what we found. So let's just start with the overall unadjusted outcomes of the series. And as you can see here, these represent expected modern outcomes for this procedure. And across the abscissa run the various echelons of experience, with the highest being of over 525 Whipples. Now, severe complications, fistula, and reoperation significantly decreased by the upper echelon, whereas failure to rescue and mortality were not associated with experience. And these latter metrics could be sensibly perceived to be under the influence of patient, institutional, or systemic variables, less than surgical prowess and repetition. But is it just that practice makes perfect, whatever the risk profile? Well, in order to provide an answer to this question, we here show risk-adjusted analysis across advancing experience tiers, represented by the blue bars here. Now, negligible low risk, represented the full third of all the cases performed, was segregated by the intermediate and high risk. Now, here we show that for severe complications, upper echelon experience matters in more risky cases, but not for those at a lower hazard. Whereas for fistula rate, well, the experience effect extends down to the low-risk cases, although in an attenuated fashion. And the same pattern applies to reoperation and duration of hospital stay. But if you remember, back to those outcomes that may be more intuitively aligned with institutional variables, well, there was no association in either risk cluster for both failure to rescue and mortality. So, to extend this even further, for added value, we performed a so-called scenario-adjusted analysis. You may be now wondering just what a scenario is. Well, a scenario is a discrete amalgamation of 4 variables: gland texture, duct size, pathology, and blood loss for each given case, and each bearing a unique outcome profile. 80 such combinations exist, and here we show the composition of scenario 54, for instance. Now, these most impactful scenarios were established and were selected as an amalgamation of those that occur most often and demonstrate the highest fistula rates. These 10 most impactful scenarios all lie within the intermediate and high risk zone and account for 35% of all Whipples and over half of all fistulas that occurred here. Now, recapitulating our earlier graphs, here you can see the outcomes in this scenario-adjusted subset. And these outcomes are, of course, naturally worse. But just as before, severe complications, fistula, and reoperations were better in the hands of the upper echelon. And once again, just as before, failure to rescue and mortality were not associated with advanced experience. So, you may be now asking just what qualifies these upper echelon most experienced surgeons. Well, they represent 15% of our study group and each bring a median of 800 Whipples and 26 years of experience. But importantly, the features of the patients they treated were identical to the patients treated by the other surgeons. So, just what do these masters do that contribute to these better outcomes? Well, they more often use PGN reconstruction, stents, and drains, while omitting somatostatin analogs administration. And indeed, when they use this best practice bundle, their fistula rates were attenuated by 2/3. Yet, On multivariable analysis, upper echelon experience was still independently associated with better outcomes. So, in a quick overview here, we can say that within this high-volume institutional setting, first, surgical experience independently impacts pancreatic fistula occurrence and its attendant effects, especially in more impactful scenarios. Second, experience seems to matter less for attaining acceptable outcomes with lower risk whipples. Third, mortality and failure to rescue appear to depend on baseline patient and institutional features. And finally, highly experienced surgeons employ a more successful mitigation strategy approach. So, in conclusion, this study hints that the path to proficiency in the now common high-volume construct travels from efficiency to efficacy. And this process relies upon core training augmented by the adoption of best practices and buoyed by institutional support. Well, I now wish to thank each of the members of the Pancreatic Fistula Study Group that contributed to this study. We are truly indebted to our collaborative group whose steadfast work has allowed for much of our work on fistula. And I will now be more than happy to field your questions, and so thank you so much for your attention.
This paper will be discussed by Sharon Weber.
Thank you so much for such a great presentation. And for those of you who have decision-making capacity in the match, Dr. Knaus is a medical student from PISA, and he is applying in the general surgery match, so look for him on your list of applicants. I want to start by thanking Dr. Vollmer for all his persistence and breadth and depth that he has contributed to this topic over the years, which clearly has increased the safety of this operation and our understanding about complications after this operation. I have a couple questions for you. One is, I think for the young surgeons in the audience, they might be a little depressed by the number of over 525 Whipples to attain proficiency. And I just really appreciate the idea of an intervention package, but I think trying to figure out, rather than looking at pure numbers, how do we use that intervention practice selectively in the right patients so that we can maybe surpass that learning curve and maybe bring down the number a little bit. And then secondly, I really appreciate looking at this as an individual and also as the institutional contributions to the learning curve, but I think there are some other things that probably matter here and may be more difficult to measure. And I think partly this gets to the learning environment, having young surgeons who are able to reach out to senior mentors, having a safe learning environment. And I just love your comments on how we might be able to transcend the single institution mentorship to look at this question more globally, but also ask the question about new technologies such as video capture and feedback and coaching and how we might be able to flatten that learning curve using some of the newer technology. Thanks for a great presentation.
Thank you so much. And these are truly great questions. And so let's start from the beginning. We may, speak about this for all the day long, but so let's try to keep on 4-5 main points. So first of all, I guess we have to keep in mind that this learning curve so essentially is associated with secular trends in pancreatic surgery. And times have changed, and practices have changed over time. I typically here ask for help from my past life and past experience as a professional pianist. And on the verge of very important concerts, my piano professor used to tell me that there was a very huge difference between being a practitioner and being a musician. And the difference was that to be a musician, you had to spend essentially 12 hours of training for 10 years. And maybe you could have been able to achieve that specific level. So the learning curve we saw here is very similar to being a musician in the field of music. But on the present, so now we have seen many changes, for example, in the fellowship training and in other practices that may shorten this learning curve. And this directly connects to the second question about what new technologies we have to essentially speed up this learning curve. And I'm quite privileged to be working at the University of Pennsylvania with Dr. Daniel Hashimoto at Penn, indeed. And we're working on the development of the so-called virtual coaching. So we're taking videos from robotic weapons in this case and analyzing specifically the anastomotic phase of the procedure. We're annotating the videos and using that to provide real-time feedback to surgeons while they perform the surgery to essentially guide them into avoiding mistakes and errors while doing the procedure. And I guess this will have a huge impact in the future about training and shortening this learning curve. And finally, about when to apply these best practice protocols. Well, our group has just published recently the so-called risk fistula catalog, where essentially we took into account all the 80 combinations from the fistula risk score and provided the mitigation strategies that may best help in each of these specific scenarios. So I refer you to that paper that may be very useful into providing an answer to that question. And thanks once again for those wonderful questions.
That's great. Well, very robust session, and they only benefit from hearing them again. So we have a brief break until 12:30 with posters, and we'll be back here. And as you know, we have Dr. Asher's session here at 2 o'clock. We also have an oral session for colorectal disease. So there's, no matter what you want to do, there's a panoply of great options for this afternoon.